Good morning, everyone. So sorry for the delay in the presentation. Today, I'm gonna present my seminar on adult attention deficit hyperactivity disorder. So basically, this is the index of the overview. What I'm gonna present through its introduction, etiology, conceptualization of adult ADHD, neurophysiology, differences in adult ADHD, screening instruments, differential diagnosis, treatment, conclusion, and references in the end. Introduction. Attention deficit hyperactivity disorder is a genetic neurobiological disorder that affects one's ability to regulate impulse control, motor activity, and attentiveness. That is disorder of executive function. Etiology. ADHD is thought to result from a complex interaction between multiple genetic and environmental factors. Genetic, twin siblings and family studies support strong genetic component in ADHD causation. Concordance rate in monozygotic twins is 59 to 92%, and in dizygotic twins is 29 to 42%. 50% chance to have the disease in one parent has ADHD, and 20 to 25% chance in first degree relative is affected. Genetic, so polygenic inheritance is present, which consists of DAT1, dopamine transporter gene, and DRD4, dopamine 4 receptor gene. Out of all of these, DRD4 is the one which we have to concentrate because this have been researched enough that it lies one of the causation of ADHD. So first, a basic overview, what we are going to talk about. It consists of conceptualization of adult ADHD. The three core symptoms of ADHD, first we're going to know what actually causes it. So first, I'm going to give you a brief overview, how it develops throughout the childhood and how it progresses in the adulthood. It consists of inattention, which basically can be concluded by examining the patient or a child by impaired attentiveness, impulsivity, impaired impulse control, and hyperactivity, impaired motor activity. Symptomatology, ADHD types, predominantly inattentive presentation, predominantly impulsive hyperactive presentation, combined presentation. In adults, symptoms of inattention are more common. Hyperactivity and impulsivity present differently. So basically, initially, when the child is small, so impulsivity and inattentiveness are the main presenting symptoms. But eventually, as one grows up into adulthood, they basically change differently, which I'm going to explain in the further slides. Neurophysiology. Noradrenergic and dopamine pathways of attention. The non-adrenergic pathway projection from the locus ceruleus in the brainstem to frontal cortex, and the dopaminergic pathway projecting from ventral tegmental area in the brainstem to mesocortical and dorsolateral prefrontal cortex. Areas may be the hypothetical mediators of attention, arousal, concentration, and other related cognitive function. If they fail to function, inattentiveness and attention deficit may result. So a basic overview about this is that the main prefrontal cortex region which is present in the brain is the main regulator of all the impulse control, alertness or attentiveness. If there is a bit in ADHD, they are not firing at the same level that it's supposed to be. So basically, if they have to run at like 10 beats per second, they have come down to 2 beats per second. So which results in main causation of the symptoms of ADHD. So we got to fine tune these symptoms by prescribing the medications or by different therapies that are going to come forward. Cognitive function in ADHD. Is it deficient? Arousal exists as if on a dimmer switch with many phases along the spectrum. Where on the spectrum one lies is influenced by several key wake promoting neurotransmitters, including histamine, dopamine, norepinephrine, serotonin, and acetylcholine. When neurotransmission is balanced, one is awake, alert, and able to function well. Alterations in the function of these key neurotransmitters, whether too much or too little, can cause cognitive dysfunction. Cognitive dysfunction in ADHD may be result of low tone, non-adrenergic and dopaminergic firing. So basically the next slide that I'm going to present will show you a basic spectrum, what arousal means and what basically if somebody is inattentive or has low of these neurochemical imbalances, how a patient behaves. So this contains a basic spectrum. So this prefrontal cortex area is mainly involved in the pathophysiology of ADHD. When it is not firing in the level that is supposed to fire, so it lies into inattentiveness and cognitive dysfunction. If it would have been at the appropriate level, then the spectrum would have changed to the more of a brighter side, which could have been in a awake and alert side. So basically the balance in middle has to be maintained. If two axes of dopamine and your norepinephrine occurs, then symptoms of panic, fear, hallucination, psychosis, or cognitive dysfunction may come as a symptomatology. So basically, this is more in a layman terms what is actually happening. Attention is the behavioral and cognitive process of selective concentration on one aspect of environment while ignoring the other things. So bottom up processing, basically how from the brainstem towards the prefrontal cortex, what is happening, and from top to down processing, how the frontal cortex towards the bottom approach. This is the basically presentation. So on the left side, you know how the tracks are moving from down to upwards, and then how the body is responding from up downwards. Bottom up processing or stimulus driven attention or exogenous attention. It is driven by the properties of the object themselves. Example, a sudden loud noise can attract our attention in a pre-conscious or a non-volitional way. We attend to them whether we want to or not. So this is what basically is happening. If there's a loud noise, suddenly our attention automatically gets diverted. This is a normal phenomenon. Then top-down processing or goal-driven attention or endogenous attention, it is under control of the person who is attending. Example, if we come across a harmful object such as hot stove, our prior knowledge and stored in memory make sure that we won't touch that thing again, mediated primarily by frontal cortex and basal ganglia. So this is basically the normal thing how we should behave. Both these processes are coordinated by prefrontal cortexes. There is dysregulation in between in them which causes ADHD. If there's dysregulation from bottom up approach due to increased exogenous attention, children with ADHD fall to sustain attention on one thing and get distracted easily by exogenous stimuli. Due to diminished top-down processing, children with ADHD fail to execute organizational tasks. They don't know consequences of their actions and are frequently prone for injuries and accidents. Inattention. So what does fall actually in inattention? Frequent careless mistakes, poor attention to details, does not listen when spoken to, does not follow through on instruction and fails to finish schoolwork or duties in the workplace, has trouble organizing activities, avoids dislikes or doesn't want to do things that take a lot of mental effort for a long period of time, loses things needed for tasks and activities, phone, keys, address books, easily distracted, starts activities but leaves it in midway, forgetful in daily activities. So most of the symptomatology you might be finding in yourself as well, but the symptoms are way more severe. There's a beautiful documentary, I don't recall its name. It shows basically three siblings all who have ADHD in them, and then it's well documented how difficult the parents' life is to manage them. Hyperactivity, fidgets with hand or feet or squirms in seat, gets up from seat frequently, restless, constantly moving, has trouble playing or doing leisure activities quietly, constantly shifts between tasks, is often on the go or often acts as if driven by a motor, talks excessively. Impulsivity, blurts out answers before questions have been finished, has trouble waiting one's turn, interrupts or intrudes on others. Example, butts into conversation or games. Accident proneness. This is one of the DSM-5 diagnostic criteria for adult ADHD, and in the next slide I'm going to compare it with the ICD-10 criteria. I have not included the ICD-11 criteria because it's not yet finalized and there's no clear demarcation to diagnose adult ADHD in ICD-11. So inattention, the basic summary, it will help you again. Comes, falls as in does not seem to listen, does not follow through on instruction, difficulty organizing tasks and activities, loses and misplaces object. So all these form under spectrum of inattention. Then hyperactivity, leaves seat frequently, always on the go, talks excessively, and impulsivity, blurts out answers, difficulty waiting his or her turn, tends to act without thinking. So this is the head-to-head comparison between DSM-5 and ICD-10 criteria. So one of the main differences that you can observe is it's called ADHD in DSM-5 and hyperkinetic disorder in ICD-10. But now it has again changed to ADHD in ICD-11. That's how they mention it. Onset, some symptoms before age of 12, some symptoms before age of 6 according to ICD-10. Symptoms criteria for children, ADHD combined. So basically if we follow the ICD-10 criteria, then the most of the children do not fall into the spectrum of ADHD. So it's basically, it is a levy that we are giving to the children if we follow the ICD-10 criteria, which is less strict as compared to DSM-5 criteria. ADHD combines 6 to 9 symptoms of inattention and 6 of 9 symptoms of hyperactivity, impulsivity. ADHD predominantly inattentive, 6 of 9 symptoms of inattention. ADHD predominantly hyperactive, impulsive, 6 of 9 symptoms. So the three categories how we define ADHD DSM is just it's a brief overview of how many symptoms are required to diagnose it into a particular subtype. in ICD-10 must have a combination of impaired attention and hyperactivity. So a combination of two is required in that. It's not just limited to just one symptomatology. The only subtype of hyperkinetic conduct disorder for those who meet criteria for both disorders. So this is an entity all together in itself, hyperkinetic conduct disorder, which is a topic of discussion on its own. Symptom criteria for person is greater than 17. According to ICD-10, must have a combination of impaired attention and hyperactivity. ADHD combined 5 of 9 symptoms. ADHD predominantly inattentive 5 of 9 symptoms. ADHD predominantly hyperactive 5 of 9 symptoms. Settings: several symptoms present in greater than 2 settings. Full syndrome in greater than 2 settings and observed by the clinician in ICD-10. Duration for greater than 6 months. Duration is the same for ICD-10 as well. Impairment: interference with social, academic, or occupational functioning includes severity specified, mild, moderate, and severe, clinically significant distress or impairment in social, academic, and occupational functioning. So one of the interesting things about adult ADHD is that never the patient comes with the complaint that I have these symptoms. It's the skill of the clinician to rule out the other comorbid conditions that might be present in the patient. So I hope so that after you go through our slides, you have another arsenal in your back pocket. So if you are ruling out these symptoms of a BPAD or substance abuse disorder, why is he getting indulged so actively? That also you understand in the further slides, that patients with adult ADHD are involved in the more drug-seeking behavior to again regulate the neurotransmitter in prefrontal cortex. So again, I can explain that in further slides, that how do we actually manage that. Now, differences in adult ADHD. The core feature is disinhibition, feeling of restlessness and difficulty relaxing, as opposed to hyperactive. Feelings of being on the go all the time, desk is cluttered and things are frequently lost. Many projects are started and worked hard on, but then abandoned before completion. So, adult ADHD symptom manifestation: hyperactivity changes to restlessness as it comes to adult ADHD. Hyperactivity in childhood often changes to inner restlessness in adulthood. Self selects very active job, is overscheduled and is overwhelmed, is a workaholic. Then again, physical impulsivity, as in children, is turned to verbal impulsivity as they grow up into an adult. Physical impulsivity in childhood often changes to verbal impulsivity in adulthood. Low frustration tolerance, quits jobs, ends relationships, drives too fast, loses tempers, talks excessively. So again, the symptomatology again looks like a bit of BPAD symptoms. Sort of quits job regularly, low frustration tolerance, anger aggressions, loses temper easily. So it's basically the skill of the clinician to again rule out if the patient might be having ADHD or is currently suffering from any other comorbidity. Then comes inattention, which remains. Inattention in childhood often remains inattention in adulthood, but carries more severe consequences. Procrastination, difficulty organizing, being late, forgetting things and appointments. Now, this is the developmental course of ADHD. In preschool, there are behavioral disturbances. So, one of the studies showed that you can't really diagnose ADHD before the child turns at least 6 years of age. So, that's why they start from the preschool itself. School age behavioral problems, academic problems, poor social interaction, comorbidities. Then as the child progresses to adolescence, academic impairment, poor social interaction again, low self-esteem. The lower self-esteem, one of the symptoms is because he's being scolded all the time by the family members. That why can't you sit at one place? Why are you moving constantly? Why can't you pay attention at anything? Both at school and both at home. So one of the symptoms comes as lower self-esteem. Smoking, alcohol, and drugs, again, one of the disinhibitory symptoms as patient is trying to regulate. Another thing that childhood schizophrenia that often is concluded that people are more involved in smoking in their childhood if they are in schizophrenic. So that can also be one of, because the major pathway which belongs to ADHD and schizophrenia share the same circuitry. College age, academic failure, low self-esteem, alcohol and substance abuse, again, comorbidities. And in adult, unable to cope with daily tasks, unemployment, low self-esteem, relationship problems, alcohol, substance abuse, mood instability, and comorbidities. Adults with untreated ADHD are more than twice as likely to have arrested, twice as likely to have divorced, more than twice as likely to have dropped out of high school, twice as likely to have held 6 or more than the past 10 years. So this was one of the articles that I found over the internet, which showed these data which had a good amount of sample size. So a p-value of less than 0.0.5. So if it goes by the article and the data that they shared, this is one of the past history that we can go through when we are taking a detailed history of an adult ADHD patient, or we are suspecting one. So is ADHD all that bad? People with ADHD can pay attention, exercise self-control, and complete tasks. When faced with a deadline, has a high, rewarding, and interesting task to complete, or in under close scrutiny, their performance may be quite good. The key in diagnosing ADHD determined by the symptoms are typically present and are more pronounced when there is less external structure and demand. There's argument about the internet as well, that is ADHD a boon or a curse? Because according to the argument that they give for ADHD is that people that are not at all attentive in the task that they don't really like, they don't take it at the first place. But the things that they really like, they can put their all the hard work on upon it. One of the symptoms is ADHD. So the screening instruments. Adult ADHD self-report scale, currently symptom checklist based on frequency, shown to be effective in personality settings, 18 items pulled from DSM-4. Then there's Connors adult ADHD rating scale, long 66 long questionnaire, is costly, is also self-report and observer report time consuming, standardized score across 9 domains. So a new scale has been developed which is better than Connors scale as it is freely available and can be practiced by the clinicians, which is known as vendor UTAS rating scale. Helps in establishing the diagnosis in childhood. 61 questions answered by the adult patient recalling their childhood behavior, free and available online. So the next slide will show a basic questionnaire, how it looks like. This contains of questions, out of which only a certain amount of questions fall to diagnose if the person is having adult ADHD. So this is a 61-point questionnaire rating from 0, 1, 2 to 3 and 4. And these are the questions which mainly regard the symptomatology if the patient is suffering from adult ADHD or not. A type of question in which patient can't think a lot of questions. So basically the content is so much because they want to rule out that patient is not trying to fake it. So in between they hide these questions and help to diagnose, give a clearer diagnosis of ADHD in adults. Now comes differential diagnosis. Besides malingering, there are a number of conditions that get confused as ADHD and need to get ruled out in making the diagnosis, like substance abuse, especially cannabis, bipolar disorder, depression, PTSD, anxiety, personality disorders, and medical conditions. Substance abuse. Daily cannabis abuse, especially starting before 16, causes severe impairment to frontal lobes, inability to concentrate. People using active opioids, cocaine, and alcohol will focus poorly and not complete tasks. 3 months of sobriety is usually a minimum for a confident ADHD diagnosis. Patient need a lengthy substance abuse history and a random urine toxicology. If history of being on stimulants, call pharmacy and get frequency of fills of both the stimulant and the medications they are taking. So there's a high possibility that patient is on stimulants, so he'll abuse it. So there's this thing that the people in the US have involved that whenever a patient is coming for the ADHD treatment for amphetamines or methylphenidates, so basically there's this rule that they have to prescribe from only one doctor itself, and they have to get checked that they are getting their refill for just one medication only. But it's very easy to fake these tests. So they constantly have this drug seeking behavior because of the euphoric effect that the patient gets after taking amphetamines. Bipolar disorder. Patients with bipolar disorder have periods of time lasting weeks to months of decreased need for sleep, increased goal-directed activity, racing thoughts. Again, one of the symptomatology that has similar presentation at ADHD. These are episodic and not chronic in nature, and the impulsivity can be confused with ADHD. Stimulants can worsen mania and psychosis, so should be used with extreme caution. Other disorders, patients with depression feel hopeless and cannot concentrate. They cannot accomplish many activities because of their downward mood, thus get confused as having ADHD again. Patient with PTSD can be easily triggered and switch from activity to avoid an emotional stimulus. Patient with generalized anxiety have chronic worries which distract them. So again, it's the skill of the clinician and the experience that comes with it that he is able to come to a diagnosis of ADHD before ruling out all these symptoms that I have just mentioned. Treatment. Goal is to reduce ADHD symptoms and improve function. Pharmacotherapy, stimulants, non-stimulants, cognitive therapy and environmental changes, and other non-pharmacological therapies which my friend Neil is going to cover in the further lectures to come. Stimulants, methylphenidate and amphetamines. Multiple formulation and delivery systems are present. Work by increasing level of dopamine and norepinephrine. Again, I want to take you back to the first slide. Dopamine and norepinephrine are plummeting down. We want to again get them back again at a higher level. So we administer them the enhancers which increase dopamine and non-epinephrine. Randomization trial has shown the stimulant outperform placebo, especially in short-term trials. One of the interesting facts that I found out over the books while I was researching ADHD was that the clinicians were able to figure out that there's decreased non-epinephrine and dopamine when they were randomly giving drugs to the patient. Then they finally understood, okay, now the drug is working, and maybe this is the reason that the neurotransmission is below. So we have no idea what the poor patient went before that. Methylphenidate, available in short and long-acting formulations, average dose 20 to 30 milligram orally in 2 or 3 divided doses, preferably 30 to 45 minutes before meals. Maximum dose is 60 milligrams per day. Time required for the immediate release formulation to show their effect is in 2 hours. For sustained release formulation, it is 4 to 7 hours, and for extended release formulation is 1 to 2 hours. Issue of up-down effect to significance is to once daily long-acting. If effect doesn't last long enough, add a low dose of fast-acting stimulant in the afternoon. Forgetful of afternoon dose, try long-acting. Patient has to be constantly on medication. He can't skip these medications as we want to maintain a certain level of drug into the blood. It could be one of the things that patient could be wary of taking these drugs is if they get too overstimulated. So a regular follow-up is required by the patient. He has to come and tell the side effects he is suffering from so that we can titrate the dose according to the symptomatology. While its exact mechanism is unclear, methylphenidate has been shown to act on non-epinephrine and dopamine reuptake inhibitors, thereby increasing the presence of these neurotransmitters in the extraneuronal space and prolonging their action. So this is a diagrammatical representation. Normally, the dopamine transmitter moves dopamine from the synapse back into the sending neuron. So there's this cycle, dopamine comes into the synapse and again is taken back again. Methylphenidate basically blocks these transporters, and there's increased availability of dopamine and non-epinephrine in the synapse, which helps to relieve the symptoms. Methylphenidate blocks the dopamine transporter, causing an increase in dopamine concentration at the synapse. Adverse effects: dry mouth, insomnia, irritability, reduced appetite, weight loss. Most of the symptoms, as you also are also present when you are increased high caffeine intake, like hyperhidrosis, irritability. One of the symptoms like tic disorders is the one thing that helps to rule out if the patient is over medicated with the methylphenidates. Now, amphetamine, mechanism of action, then I'll show you the diagrammatic representation. This is very important as it has become an increased problem in the US as people are now self-diagnosing themselves as ADHD and they reach the clinicians for the drugs for the stimulant-seeking behavior as it's only a prescribed only drug. So this is unlike methylphenidate action of DATs and NFT. DATs again dopamine transporters and non-epinephrine transporters which are not competitive. Additionally, since amphetamine is also a competitive inhibitor of VMAT, VMAT is basically a regulator of the vesicles, which helps to again replenish the stores before it goes into the synapse. Is actually taken into the DA terminal via DATs, again are the dopamine transporters, where it can be packed into vesicles. At high levels, amphetamines will lead to the displacement of dopamine from the vesicles into the terminal. Furthermore, once a critical threshold of DA has been reached, DA will be expelled from the terminal via two mechanisms. I will help you understand this slide in the next slide by the diagrammatical presentation. So here, what is happening in the first slide? It's basically the yin and the yang, how the increased level of dopamine and non-epinephrine might affect and have cause symptomatology. If we are trying to treat the patient, we might overtreat it and have other side effects. So in the first image, we are saying these are the transporters. So they basically reuptake the dopamine, and so the thing in the saffron is the competitive antagonism, and the one with the arrow in the blue is the dopamine. So the competitively they inhibit the reuptake. So rather than the transportation of dopamine back into the circulation, amphetamine is getting taken upside. I will repeat it again. The ones in the blue text is the dopamine, which is the neurotransmitter. But once we administer amphetamine, rather than the dopamine getting transported back into the vesicle or in the presynaptic neurons, amphetamine is getting transported again. Then in the second image, there's more availability of amphetamine in the vesicles now. So dopamine again gets replaced from the vesicles and is lying in the presynaptic space. So due to the high concentration of dopamine lying in the presynaptic space, there is increased leakage of dopamine in the last slide, which causes this euphoric effect that we get after that people get after taking amphetamines. So basically it's not letting dopamine to stay where it's supposed to stay, neither in the vesicles nor in the postsynaptic cleft. So there's increased availability of dopamine. That's why there are increased chances of abuse with amphetamines. Then there's atomoxetine, which is a non-stimulant, dosing 40 milligrams per day for 3 days, then 80 milligrams per day. Non-stimulant selective non-epinephrine reuptake inhibitor. Ideal choice for patients with substance abuse history. However, many patients find it ineffective and unhelpful. Contraindicated in cardiomyopathy. Atomoxetine in ADHD with weak prefrontal cortex, non-epinephrine dopamine signaling. Again, the same cycle: decreased dopamine, decreased non-epinephrine, atomoxetine again to increase the level of dopamine and non-epinephrine prefrontal cortex. Through its blockade of non-epinephrine transporters, atomoxetine causes neuroepinephrine and dopamine levels to increase in the prefrontal cortex, where inactivation of both of these neurotransmitters is largely due to non-epinephrine transporters. At the same time, the relative lack of non-epinephrine transporters in nucleus accumbens prevents atomoxetine from increasing non-epinephrine or DA levels in that part of the brain. So if we are trying to treat the symptomatology, the drug doesn't know where it's supposed to act. Either it can act on the frontal cortex, or it may even disturb the balance in the midbrain or nucleus accumbens, which may also have problems with the nigrostriatal pathway, which may also lead to motor disturbances. So atomoxetine is the safer drug of choice because it only has specificity on the prefrontal cortex. Other medications like tricyclic antidepressant or venlafaxine, alpha-2 agonist, clonidine, guanfacine, SSRI are really helpful for attention deficit symptoms. In conclusion, diagnosis of ADHD requires a thoughtful history taking and clinical judgment, as well as ruling out most other possibilities. Treatment can be very helpful to some people and frequently requires treating other diagnoses first. Watch for mania and psychosis. These worsen significantly on amphetamines and stimulants. A high heritable condition starts in childhood and persists into adulthood. Diagnosis is made based on clinical presentation. Treatment and with stimulants through second-line medication are also available. These are my references. Thank you.